My name is Ashley Stuckey, and today we'll be discussing moving beyond the BRCA mutation, what every OBGYN should know in 2017. I have nothing to disclose. Today we will identify patients at risk for an inherited cancer syndrome in your OBGYN practice. We will define prophylactic options for women with inherited gene mutations, and we will describe novel cancer genes and comprehensive genetic panel testing. As many of you know, Angelina Jolie disclosed several years ago to the media and to the world that she had a BRCA mutation. Thanks to her, the BRCA mutation has become very widely known among patients and providers in the United States. Today we will talk about identifying women who are at high risk for these mutations. Well, I think to start we need to discuss how much breast and ovarian cancer is truly hereditary. It's actually a very small number. Only 10 to 15% of breast cancer is considered hereditary, and 20 to 25% of ovarian cancer is considered hereditary. However, the BRCA mutations are responsible for approximately 25% of early onset breast cancer. In terms of how prevalent the BRCA mutation is, we see it in about 1 in 800 in the general population. It is much more common, though, in patients of Ashkenazi Jewish heritage, and we see it in about 1 in 40 in these people. There are some clinical features that do suggest a BRCA mutation. Things to look for in your patients or their family members may be multiple cases of premenopausal breast cancer, a personal history of serous ovarian, primary peritoneal, or fallopian tube cancer, breast and ovarian cancer in the same woman at different times, bilateral breast cancer. Again, these can be diagnosed at the same time or diagnosed at different times. Any person with Ashkenazi Jewish heritage with breast and or ovarian cancer. Any male breast cancer, multiple prostate cancers in males, especially at younger ages, or pancreatic cancers. Any family members who test positive for a genetic mutation. Any female with triple negative breast cancer less than 50 years old without a family history or greater than 50 years old with a family history. And finally, DCIS at a young age with a family history of breast cancer. Once a patient has been tested for the BRCA mutation, it's then important to know how to interpret the results. A lot of times it's not as easy as positive or negative. We know obviously that a positive result means that these patients have a significantly increased risk of developing a cancer, and we have screening recommendations that we can follow for mutation carriers. For somebody who has a negative test result, the family history then has to be interpreted. If there is a known mutation in the family, the cancer risk would revert back to general population for this patient, and they could undergo standard general population screening. However, if there is no known mutation in the family, the cancer risk will be based on family history data, so the screening will need to be tailored based on this level of familial risk. And finally, an inconclusive result is also called a variant of uncertain significance. These variants will typically be reclassified as more data is collected by the genetic testing companies. However, it's important to have these patients follow up on an annual basis so that if a variant is reclassified as deleterious, then these patients can be correctly screened in a high-risk fashion. For those patients who have variants of uncertain significance, we do typically not alter their screening, but perform screening based on familial history. Other associated cancer risks with the BRCA mutation would be male breast cancer. This is more common in BRCA2 carriers than BRCA1 carriers, and the risk is about 7% by age 70. Prostate cancer is also more common in BRCA2 carriers. The risk is approximately 33 to 39% by age 70, in contrast to 7% in the general population. Pancreatic cancer is also more common, again, more so seen in BRCA2 carriers than BRCA1 carriers, and this risk is 2 to 8% by age 80, and in the general population it is less than 1%. Finally, malignant melanoma is more common in BRCA2 carriers as well, and this risk is about 5%. Ocular melanomas can also be seen in BRCA mutation carriers. Once we have this information about a patient's BRCA status, the hope is that prevention is better than cure, and we do have very good ways to prevent breast cancer. Breast self-awareness is something we discuss. This is the new term for breast self-exam. This typically can be taught and explained to a patient, and they may start performing breast self-exam anywhere after age 18. Regular clinical breast exams are also recommended every 6 to 12 months starting at age 25. We do begin imaging at age 25, and for those who are between age 25 and 29, we recommend annual MRI. We do not recommend mammograms in this age group due to the younger age and the higher exposure of radiation that they will be receiving over their lifetime with the mammogram screening that they will undergo. And women between age 25 and 29 have very dense breasts, so a mammogram is typically not very useful in screening the breast. After age 30, though, we do recommend annual mammogram and MRI alternating on an every 6-month basis. So, for example, the patient would receive a mammogram in December and an MRI in June, and that pattern would continue alternating. And then finally, we do have risk reduction strategies that are available. Prophylactic bilateral mastectomy is an option for these women. This decreases the risk of breast cancer in BRCA carriers by more than 90%. We are performing skin and nipple-sparing mastectomies, and this is something that we know does not increase the risk of a local recurrence in a patient or increase their risk of developing a cancer in the nipple areolar complex if they have not had a breast cancer before. This provides a superior cosmetic result rather than the traditional total mastectomy or simple mastectomy. Reconstruction is often done at the same time as the mastectomy in these patients. Insurance does provide coverage for reconstruction. Prophylactic bilateral salpingo-frectomy is recommended between age 35 and 40 for BRCA1 mutation carriers. For those who have BRCA2 mutations, we are now recommending bilateral salpingofrectomy between ages 40 and 45, which is a little bit later than when it had been recommended previously. This is typically recommended at a later age because women with BRCA2 mutations tend to develop ovarian cancer later than women with BRCA1 mutations. We do counsel these patients that the age 40 to 45 is preferred when they've already maximized their breast cancer prevention, i.e. had a mastectomy, but certainly looking at family history of when the earliest ovarian cancer was diagnosed in the family is also important. But in general, we do recommend women with BRCA2 mutations have their BSO between ages 40 and 45. Having a BSO does reduce the risk of developing a breast cancer by 50% as well. Hormonal replacement therapy is recommended in unaffected carriers until the natural age of menopause around age 50 or 51. This has not been shown to increase their future risk of developing a breast cancer. We do know that oophorectomy reduces mortality from breast cancer. Several studies have looked at this. Most recently, there was a study looking at 676 women with stage 1 to 2 breast cancer who also had BRCA mutations. 345 women had a BSO and 331 patients did not. And these patients had their BSO or did not have their BSO after they were diagnosed with breast cancer. They were then observed for 20 years. The study showed that BSO reduced the breast cancer-specific mortality in BRCA1 carriers. BSO also provided a survival benefit in women who had ER-negative tumors. And the benefit did seem to extend to women who were diagnosed after the age of 50. So given this data, we do discuss BSO at diagnosis of breast cancer for BRCA mutation carriers, as it may possibly be therapeutic as well as preventative. One of the questions that has come up recently is whether hysterectomy is necessary at the time of BSO for prophylaxis. This study, published by Xu et al. In 2016, asked whether women with BRCA mutations who undergo risk-reducing salpingo-frectomy without hysterectomy are at an increased risk for uterine cancer as compared with the expected rates from the Surveillance, Epidemiology, and End Results Database, or SEER database. They found that in this prospective cohort study, there was no increased risk for endometrioid carcinoma or serous carcinoma. During a median follow-up of 5.1 years, however, 4 serous and/or serous-like carcinomas were seen in 627 women with BRCA1 mutations versus a much lower expected rate, which was a significant difference. They concluded that women with BRCA1 mutations do have an increased risk for serous and/or serous-like endometrial cancers, and this should be considered when discussing advantages and risks of hysterectomy at the time of BSO. Overall, they noted that for BRCA1 mutation carriers, the 25-year risk of an endometrial serous cancer was between 2.6 and 4.7%. There are certainly pros and cons to this. Pros for performing a hysterectomy would be, again, this study did show a small but significant increase in the risk of serous cancers. 5 were observed. And among those who had BRCA1 mutation carriers, we can see that there was also a higher risk of developing a serous or serous-like cancer. Again, they observed 4 cases. The con side would say that we were only seeing 8 uterine cancers out of 1,083 women, which is a prevalence of 0.7%, which is very low. 5 out of these 8 were serous cancers, which means 5 cases out of a total of 1,083 women had serous cancer. So the overall risk of serous cancer is still very low at 0.4%. So I think the bottom line is that there is no significant increased risk of uterine cancer. However, one must discuss this data, and although it is early, further data in the future may come to light to show that there is a significant benefit to performing hysterectomy at the time of BSO. One must discuss with the patient risks and benefits of the additional surgery, recovery time, and possible complications of adding a hysterectomy to the BSO. Chemoprevention is also an option for these women. Tamoxifen, which is a SERM, has been shown to reduce the risk in women with moderately high risk of breast cancer by 50%. There was one study that looked at women who had BRCA mutations, and they saw a 62% risk reduction in those who had BRCA2 mutations. There is limited data for use in the BRCA1 population, and again, these women are more likely to develop ER-negative breast cancer, so the utility of tamoxifen may be small. Raloxifene is another option. This is a SERM as well. This has not been shown to be as effective as tamoxifen, but it does have fewer side effects. Tamoxifen, as many of you know, does increase the risk of thrombosis and slightly endometrial cancer, as well as cataracts. Exemestane and anastrozole are also options for women. These are aromatase inhibitors, and they seem to have a comparable risk reduction in postmenopausal women as compared to tamoxifen. For women who are of reproductive age, there are options for them with assisted reproductive technology. These women may undergo a cycle of IVF and then have pre-implantation genetic testing done to identify those embryos without BRCA mutations, and then they may choose to implant only the embryos without a BRCA mutation if they so wish. This is something that should be discussed with all BRCA carriers when they are of reproductive age. Changing gears to Lynch syndrome. This is an autosomal dominant genetic mutation that carries an increased risk of endometrial cancer by about 60%. There's obviously also an increased risk of colorectal cancer between 30 and 60%, and the risk of colorectal cancer seems to be higher in men than in women. There's also a risk of ovarian cancer of about 12%. Other cancers included in Lynch syndrome would be gastric cancer, hepatobiliary cancer, ureter or renal pelvis cancers, small bowel cancers, brain and central nervous system cancers, pancreatic cancer, as well as sebaceous adenoma or carcinoma. There has been some data recently suggesting that breast cancer may be related to Lynch syndrome. In several studies in Europe, the risk of breast cancer has been shown to be slightly increased in those patients who have Lynch syndrome. In the United Kingdom, one study was done which showed a risk of breast cancer up to the age of 70 years to be 19% in MLH1 mutation carriers and 11% in MSH2 carriers. In Australia, one study showed a 4-fold increased risk of breast cancer in unaffected mutation carriers. And in one study of Dutch and German people, the lifetime risk of breast cancer was 14% in affected mutation carriers. Overall, the data has not been clearly shown to promote a link between breast cancer and Lynch syndrome, and in fact, the NCCN in 2017 reports that there is insufficient evidence and that these patients should be managed based on their family history. Currently, universal testing for endometrial cancer is being done at many sites. At our own institution in Rhode Island, we have been performing this since 2013. So all patients with an endometrial or colon cancer, when they have their surgery, their specimen is sent for IHC for the MMR enzymes. Depending on the expression, these patients will then be either sent to genetic counseling for further germline testing or will be able to be ruled out for carrying a Lynch syndrome. This certainly may have a potential impact on future care for these patients and their family members. In 2015, there were approximately 54,000 new cases of endometrial cancer in the United States. And between 1,300 and 2,100 did have Lynch syndrome, which is about 2.5 to 4%. Additionally, 2,700 to over 10,000 of their relatives will also have Lynch syndrome. So this is certainly significant in terms of affecting screening and prophylaxis for these high-risk patients. Additionally, over 13,000 individuals who could be diagnosed with Lynch syndrome per year will be diagnosed with universal screening. So this is certainly something to think about and to ask about whether this is available at your institution. Overall, I think genetic testing is underutilized. There are over 35,000 living breast cancer patients who carry a BRCA mutation, and only 30% have been identified. There are approximately 220,000 current BRCA mutation carriers in the United States, and fewer than 10% have been identified. We know that there is effective prevention and surveillance available, so this is something to certainly consider when you see patients on an annual basis, to continually ask about updates in family history, as you may be able to pick out patients who are at high risk for having a genetic susceptibility syndrome. Thank you.
Okay, thank you, Dr. Stuckey. Now you have a background on BRCA and Lynch. I'm going to move on to the novel hereditary breast ovarian cancer genes. So before 2013, we used to look at the inheritance of one cancer-causing gene at a time. And this single syndrome testing we know was missing families with hereditary germline mutations. And looking for additional genes was very time-consuming and expensive. And so after 2013, multi-gene or multiplex next-gen sequencing was introduced to the United States, and this caused a dramatic change in enabling us to simultaneously look at dozens of genes at one time at a comparable cost to that of single gene testing. This schematic shows Sanger sequencing versus next-gen analysis, and you can see that Sanger sequencing is limited and looks at one sequence read per base pair, whereas next-gen looks at multiple sequence reads per base pair, so millions of DNA strands are sequenced in parallel and yields a much higher throughput. Oftentimes, when pathogenic or variant is found on next-gen, they will confirm with Sanger sequencing, but next-gen analysis is for sure the most common analysis ordered today. Okay, I think we're all familiar with myriad genetic laboratories that have been offering BRCA testing for many years. I carried a patent on this analysis up to a few years ago. A few years ago, the Supreme Court overturned that patent, and so many labs now are able to offer BRCA analysis. And at the same time, next-gen analysis was offered. And so there are many, many labs now that we can choose from to order not only BRCA testing, but panel analysis, which I think is advantageous. However, as you'll see, can present many complexities and challenges to not only the patient, but to the ordering practitioner. There are different types of panel tests that are offered through these different labs. This slide is showing the difference between cancer panel analysis by organ system or tumor type compared to pan-cancer analysis. And so Ambry Genetics and other labs are offering panel testing by organ system. So they'll have one panel that offers and analyzes genes just related to hereditary breast cancer, and they call that the BreastNext panel. They have an OvaNext panel, which offers genes that carry increased risk for ovary cancer. They have prostate next panels. They have brain next panels, where University of Washington Myriad offer pan-cancer panels, and so they offer analysis of all their cancer genes in one panel. So whether or not you're concerned for hereditary breast cancer or colon cancer in your patient, when you order a pan-cancer panel, it's important to understand that you're also going to be testing your patient for hereditary gastric cancer genes, colon cancer genes, which can initially seem advantageous for your patient. However, we are finding unexpected findings which present a lot of challenges in terms of interpretation and management for our patients. So panel tests continue to change. This is an example on the right-hand side of the MIRIS panel, where last year they added POL, POLD1, and GREM1, which are genes that are related to hereditary polyposis. Just last month, DICER1 was added to the OvaNext panel, so a panel just related to hereditary ovary cancer genes. I think excitingly, there are now custom panels offered by many labs, and so you can sit down with your patient based on your clinical assessment and counseling, offer them panel analysis for genes that you know are going to address the concerns and the cancer risks that you're most concerned about for that patient and their family. And then there are genes that are being taken off some of these panels, like the STK11 gene out at the bottom. This is no longer included in some of the breast panels that are available. So I think it's important that practitioners stay attuned and up to date with what types of genes are being offered on these panels, because they are changing, and it's important to know what you're testing your patient for so you're able to obtain informed consent. So the pros and cons of multiplex panel testing. It allows for similar analysis of multiple genes compared to single gene analysis in regards to cost. There are several different labs that are offering panel testing of different genes, which is important to understand. And as I've shown you, there's different panel arrangements depending on the lab that's offering the test. And insurance companies have different rules and requirements based on the panel tests that are offered through these different labs, which again is a bit complicated but important to understand for your patients. And it's an interesting time in genetics where you typically are able to offer your patient panel testing for little to no charge at this time. So this slide exemplifies the different breast cancer susceptibility genes, and on the upper left-hand side you can see the classic high-risk alleles that I think we're all familiar with, BRCA1, BRCA2, TP53 causing Li-Fraumeni syndrome, P10 causing Cowden syndrome, CDH1, which is hereditary diffuse gastric cancer, and STK11, which is Pucci-Argyll syndrome. All of these syndromes are well established, and these mutations carry very high risk for development of breast cancer. Whereas in the middle, you can see the moderate risk genes, and these are the somewhat novel genes that we are discovering carry increased risk of breast cancer, but not as high as the kind of classic syndromes that we have kind of known and understood to cause hereditary breast cancer. And you see an arrow there pointing up because the PALB2 gene, as you'll see, does seem to carry a higher risk than these other moderate risk genes, and is falling now into the category of the high-risk alleles compared to these moderate, lower-risk novel genes that we've discovered. And on the right-hand side are examples of SNPs, or single nucleotide polymorphisms, and this is a result of GWAS studies. And these lower penetrant mutations, I think, are very interesting, and we're going to hear a lot more about, as I think they're going to be combined with risk assessment models like the Gale model or Tyrer-Cuzick model to assess breast cancer risk in our lower risk patients. However, I think the data is at this point a bit premature to integrate into our clinical practices at this time. So this is the list of the high penetrant gene mutations, as I noted in the last slide, and the syndromes that I think we're all familiar with. And as you can see, PALB2 has been added to this list of high-risk genes. And this is showing pretty significant lifetime risks of breast cancer of at least 40% or higher. I wanted to talk about the PALB2 gene specifically, and this gene we know carries about a 33 to 58% lifetime risk of breast cancer when we find a pathogenic mutation. And the higher risk, it seems, associated with PALB2 families who have a stronger family history of breast cancer. The gene was initially discovered as a pancreatic cancer gene, and so I think the data is still evolving. However, the data seems pretty confirmatory in regards to a pancreatic cancer risk within these PALB2 families, and I think we'll see more data in this regard. The risk of ovary cancer is really in debate. I think that there are some researchers that really feel there is a significant and established risk of ovary cancer with PALB2 gene mutations. However, I think others feel the data is still a bit premature in this regard. So according to the NCCN, they do recommend that MRI be integrated at the age of 40 with yearly mammography in PALB2 carriers. This would be, of course, younger if family history indicated younger ages of breast cancer onset. It's unclear whether or not these patients should be considering prophylactic bilateral salpingo-oophorectomy, and I think family history should be a strong indicator at this point. Now, as you'll see in the next slide, families who have pancreatic cancer and PALB2 mutations seem to benefit from endoscopic ultrasound and MRI of the pancreas. And so this next slide is showing the results of the CAPS-4 international trial, and this consortium came together to look at that data. They found that the patients that were part of this cohort did seem to benefit from yearly endoscopic ultrasound and MRI of the pancreas, yearly alternating, and very early disease was identified, which is exciting. And in this cohort were PALB2 mutation carriers who had one first-degree relative with pancreatic cancer. And so I think most high-risk clinics are discussing screening for pancreatic cancer in individuals who are PALB2 positive, having family history of pancreatic cancer based on this data. It's not part of our national criteria yet, but I wouldn't be surprised if this is something we're going to see in the near future. The next slide lists our moderate risk genes. And so these are those genes that we now know do associate with an increased risk of breast or ovarian cancer, however, seem to be much lower than BRCA and those high penetrant genes mentioned earlier. So the odds ratio are shown for the risk of breast cancer with ATM, CHEK2, NBN, and NF1. And you can see that they are much lower, although significant in regards to or compared to the general population risk for breast cancer. And there's differences between the type of mutation in CHEK2 and the risk of breast cancer, which you'll be hearing more about. BRIP1, RAD51C, RAD51D are all associated with a moderate increased risk of ovarian cancer and do not have data confirming an increased risk of breast cancer that would indicate change in management other than family history. I list below MRE11A, RAD50, and BARD1 because these three genes are commonly on pan-cancer panels or breast panels. However, we really don't have clear evidence of the cancer risks associated with breast and ovarian cancer with mutations on these genes. So it definitely becomes a dilemma when you have a patient who undergoes panel testing and is found to have a pathogenic mutation on one of these genes, because the management at this point should really be based on family history. So understanding these mutations is not impacting management or risk assessment for the patient or family members, at least at this time. So let me go through each gene in regards to what we know about cancer risks and management. ATM gene seems to carry about a 35% risk of breast cancer, lifetime risk of breast cancer with pathogenic mutations. The pancreatic cancer risk is unclear. However, again, there does seem to be building evidence that there is an increased risk of pancreatic cancer in ATM carriers. And you can see that the type of mutation on ATM does seem to change the risk assessment for breast cancer. So missense mutations do carry a higher lifetime risk for breast cancer compared to truncating mutations. The NCCN guidelines are currently recommending MRI to again be integrated annually with mammography at the age of 40. Of course, again, younger if age is indicated in the family history. There was some concern about radiation exposure in these ATM carriers, potentially increasing risk in the radiated area. However, at this time, there really is no evidence to confirm these concerns, and so there's no evidence to recommend against radiation for these ATM carriers at this time. These moderate risk genes do carry increased risk, but most of them, as you'll see, don't seem to have a high enough risk to show evidence to support a clear recommendation for prophylactic bilateral mastectomy for these patients. However, this should be addressed on a case-by-case mutation and basis in regards to how the patient is feeling and their family history. CHEK2 carries about a 20 to 44% lifetime risk for breast cancer. Again, the type of mutation, as I mentioned earlier, does make a difference in terms of risk, where the most common mutation we have known, called 1100-del-C, does seem to carry a much higher risk than missense mutations. We do see what we believe to be a moderately increased risk for colon cancer, where the NCCN guidelines are now recommending colonoscopy to begin at the age of 40 rather than 50 and repeating every 5 years. In regards to the increased risk of breast cancer, MRI is recommended to be integrated into the annual mammography starting at the age of 40. NBM mutations carry about a 35% lifetime risk for the development of breast cancer. The risk of ovary cancer is unclear. And it should be noted that data regarding NBN mutations and cancer risks are only limited to one specific mutation that has been identified. So we need a lot more studies to better understand cancer risks and management for our NBN families. At this time, our national guidelines are supporting MRI annually with breast mammography starting at the age of 40, and again, insufficient evidence to really support recommendation for prophylactic bilateral mastectomy. And then finally, in regards to increased risk of breast cancer, patients that had neurofibromatosis type 1 clearly have an increased risk for the development of breast cancer that can range between 25 and 30%. Mammography and MRI are recommended to begin younger, so beginning at the age of 30. And interestingly, it doesn't appear that these patients have increased risk over the age of 50. And so that increased imaging doesn't appear to be necessary after the age of 50. BRCA1, RAD51C, RAD51D are all related to increased risk of ovarian cancer. You can see that it's ranging from 4 to 12%, so nothing seems to be that significant. However, when compared to the 1.4% general population risk, this risk does become concerning, especially in light of our inability to identify ovarian cancer with our current screening techniques. NCCN guidelines are recommending that prophylactic bilateral subpingual oophorectomy be considered in these patients between the ages of 45 and 50, and of course younger if we're seeing ovarian cancer diagnoses at younger ages in these families. So be careful. The cancer risks can vary based on gene mutation. So we're clearly seeing a genotype-phenotype correlation in these moderate risk genes, which is interesting. And as I pointed out, outside of specific founder mutations in CHEK2 and NBN, the cancer risk really remain unclear. ATM is considered a moderate breast cancer risk gene. However, there are 2 specific missense mutations that have been identified that we think confer about a 60% cumulative risk for breast cancer. And BRCA1, as you've seen, is a moderate risk ovarian cancer gene. However, there has been an Icelandic mutation that seems to carry a much higher risk compared to other mutations on this gene. So we for sure need more national and international collaborative research registries and trials to more clearly understand the cancer risks associated with these novel gene mutations so we can better care for our patients. So I wanted to show you a result from one of our patients who underwent a pan-cancer panel through Myriad Genetics. As you can see down at the bottom, she had many different genes analyzed related to breast, ovary, colon, hundreds of pathogenic mutations that were negative. However, her result shows that on her CHEK2 gene, there was a variant of uncertain significance identified noted to be C.470T greater than C. And I point this out because variants are seen in much greater percentages when we're doing these panel testings. But what is a variant? A variant is a change on a gene for which we really don't have sufficient information to categorize this change as pathogenic or benign. And as we are testing more genes in these panels, the risks of variants are increasing. Most of these variants are going to be benign polymorphisms, and for this reason, we should never use these variants to make clinical recommendations or offer predictive testing to family members because we really don't know what they mean, and the likelihood is that they will eventually be categorized as benign. When you find a variant of uncertain significance in an individual, cancer risks and management should really solely be made based on the cancer family history that you're seeing. So luckily there are many research initiatives that are underway that are helping us better understand variants of uncertain significance on these genes as well as mutations on these novel genes in regards to cancer risks. The PROMPT database is a prospective registry of multiplex panel testing. It's a voluntary patient-oriented registry, so our patients are able to log on and input the information if they've been found to carry a variant or a pathogenic change on a novel mutation. This is backed by UPenn, the Dana-Farber, Memorial Sloan Kettering, as well as other commercial labs. ClinVar is a publicly available database for laboratories to submit variants and the interpretation of their variants. This is becoming a great resource for cancer genetic practitioners, as it's helping us understand how different labs are interpreting variants that are being discovered on these genes. Know that some labs do not participate in the ClinVar database, so this is voluntary, and labs do not have any type of restriction in regards to when they need to update this information. But understanding the limitations, it still is becoming a great resource for us, and I'll give you an example of that in the next couple of slides. Enigma and SIMBA are international databases looking at the significance of BRCA mutations and other known or suspected breast cancer gene mutations, as well as investigating modifiers of BRCA1 and BRCA2. So here's some data from the PROMPT database. This data looks at about 1,200 patients who were tested, and they self-enrolled in PROMPT. It examines about 600 variants that were reported. And I want to point out the red part of that pie, where there was 155 of these variants that had conflicting interpretations amongst the different labs. So the same variant on a gene could be categorized different ways depending on which lab tested that patient. And the graph is showing that CHEK2 and ATM were the most common genes that had conflicting interpretations. Most concerning in this data was that 11% of these conflicting interpretations ranged from pathogenic to a variant of uncertain significance. So depending on which lab you used, you could be presenting your patient with the same genetic change, where one would be calling it damaging and carrying increased risk for cancer for that patient and their family, where another one would be calling it a variant for which we know we don't use in terms of changing management. And so we see that this conflicting interpretation is altering how we're recommending medical management for patients and their families, which is causing a lot of complexities and concerns in regards to panel testing. And this is an example of the ClinVar database. And I'm inputting here the specific CHEK2 variant that was discovered on the test report that I had shown earlier in the talk. And so this is showing that the specific C.470T greater than C variant was put into the ClinVar database, and we know that the lab that we tested our patient for categorized this change as uncertain. But when I look at how other labs are interpreting this same change, and you can see the laboratories down the right-hand side and their interpretations down the left-hand side, you can see that most of them are actually feeling there's enough evidence that this CHEK2 change is pathogenic or damaging the gene, and therefore causing increased cancer risks, breast and colon, as I've shown you, which would alter a patient's management. And so now what do? How do you counsel your patient? You're presenting them with a copy of their test report that's saying uncertain. However, I think it's our clinical obligation to inform them that there are other laboratories and other evidence that is showing that this actually could be pathogenic. And it may be the more responsible thing to do to recommend that this patient begin MRI screening at a younger age, as well as colonoscopy screening at a younger age and at a more frequent basis. Okay, so this is a summary slide just showing the management of the increased risk of breast and ovarian cancer with these novel gene mutations. And I just wanted to point out the importance of using family history in these CHEK2 missense mutation families, as well as the families having the BRCA1, RAD51C, RAD51D mutations, which indicate at this point only increased risk of ovarian cancer. And that, as I mentioned before, I think there's a lot of debate in regards to the increased risk of ovarian cancer associated with PALB2 mutations. However, I think the most important thing is really looking at the family history to try to understand if prophylactic oophorectomy should be discussed in a PALB2 family. So I want to shift gears and just discuss a couple of studies showing how often we're seeing mutations in these novel hereditary breast ovarian cancer genes. So this study by the JCO in 2016 looks at 2,000 women diagnosed with breast cancer who are BRCA1 and BRCA2 negative compared to 2,000 controls. They looked at an 18 gene panel, and they found that approximately 4% of their patients who are BRCA negative harbored a novel hereditary breast ovarian cancer gene compared to 1.6%. And that's generally what we're seeing in the studies. However, this might be a bit low as it may be solely related to our breast families, as our clinical experience alone seems to be deeming a bit of a higher percentage than the studies that are being published. This study also, I think, is interesting in that the highest mutations were identified on the TP53 gene causing Li-Fraumeni syndrome, and the PALB2 gene, which is a bit different than the previous studies. And STK11 mutations were not seen in either the cases or controls, which is perhaps why it's falling off some of the breast cancer panels, as I mentioned earlier in the talk. This is showing a broader study looking at not just breast cancer patients. It's looking at panel testing in cancer genetic practices. So these practices are addressing all types of cancer risk in affected and unaffected patients. They had 403 panel test results, and they had a 17% positive yield. This might be a little high because the positive cohort also included BRCA1 and BRCA2. Interestingly, there was a very high variant rate of 42%. And I just wanted to point out that CHEK2 was the gene that carried the highest number of patients with mutations, and BRCA1 and BRCA2 patients in combination equaled that of those that had CHEK2 mutations in this study. So panel test results can be challenging, and there are different possibilities when a high-risk gene mutation is off phenotype or discordant with personal or family history. And you'll hear more of this at the talk, at the meeting. However, we do find that different families carry, for example, CDH1 mutations carrying an increased risk of hereditary diffuse gastric cancer when we don't see diffuse gastric cancer in these families at all with the mutations. And it could be due to the fact that there's rare or novel genotype-phenotype correlations. There could be mosaicism. The finding could be de novo, or we could just have limited family structure information. We've seen that the same genetic change can be classified differently depending on the lab. Cancer genetic counseling and management recommendations are complicated, and really at this point management is typically based on genotype instead of phenotype or family history. And counseling sometimes has to redirect the patient's focus on cancer risks that may not have been expected. And this increases the importance of comprehensive pre-test counseling for these patients to make informed consent prior to panel testing. So counseling for panels is complex and presents new challenges. And so communicating the same amount of information to a patient about panel testing compared to when we were offering single gene testing is definitely information overload. And it's time prohibitive to address each gene on these panels. So we need new methods to obtain informed consent from our patients. ASCO presents a nice policy statement and I think brings up some important points that we should think about when offering or when counseling our patients for multi-geneplex panel analysis. So they point out that maybe these genes should be batched. So should we be talking about low-risk genes compared to high-risk genes? We should be perhaps mentioning that there are high penetrant syndromes in these panels, even if we're not seeing the phenotype that we would typically expect. We're finding incidental mutations, so patients need to be prepared that even though we aren't seeing colon cancer in their family, it's possible we could discover that they carry an inherited colorectal cancer gene mutation. There are positive results in less well understood and penetrant genes. We're seeing these higher variant rates, as I pointed out, and there's potential reproductive implications like BRCA2, where patients who are biallelic for ATM and PALB2 are implicated in very severe childhood conditions such as ataxia, telangiectasia, and Fanconi anemia. So in summary, the pros to panel testing is that it's more time and cost efficient. It corrects for small families or unknown family histories. It eliminates the need to recognize complicated syndromes. It can reveal risk for cancers not recognized by the family history. And the more mutations that we're able to detect, the more that we are learning about the phenotype and genotype of new conditions as well as established syndromes. As you've seen, that the frequency of variance is much higher when offering panel testing. The risks of breast and other cancers are not well understood for many of these mutations. And we don't have any criteria or understanding of who we should test, who we should offer panel testing to. Should it be every patient or family that has been tested for BRCA and is negative? Are we obtaining informed consent properly? What should be new strategies for counseling these patients so we know patients are comfortable with panel testing and the results that they're going to be faced with? And we need a better understanding of patient outcomes and whether or not this is cost effective for society. Okay, so in summary, panel test is helping us understand high-risk BRCA negative families. There's insufficient data. They're given for the near term in terms of high risk, high variant rates, variable penetrance, and uncertain disease linkage. Patients with strong family history with previous negative genetic testing may benefit from genetic follow-up, which we are for sure seeing in our clinic. But things have become more complicated, and as Robson et al. Quotes in a JCO publication, that it's important that providers with particular experience and assessment of inherited cancer risk be involved in the ordering and interpretation of cancer panel tests. We'll give a lot more examples of the cases that we're seeing in our clinics that again, point out some of the complexities with panel analysis. Okay, thank you for your time.